بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين. السلام عليكم ورحمة الله وبركاته. I promised that we will have a workshop in evidence-based medicine and how to do critical appraisal for the articles. Before we proceed for critical appraisal, we are going to talk a little bit about basic statistics, just a revision for the basic statistics. When you have a question in your mind, do I have to follow this medication or the other medication? You go ahead and search. Search the PubMed, search the articles, and you will find that there is 100 to thousands of publications on the same topic. The question will come to your mind, which one of these article I'm going to follow? Which one of these study I'm going to follow? While you are going with us in this lecture and the next lecture, you will be able to differentiate which article specifically related to your question and which article you can rely on it to follow in your patients. When we are reading any articles, we can see a lot of the measures, tools to measure. And these tools could be the mean, median, mode, standard deviation, confidence interval, the probability value. In this lecture, we are going to shape these measures into imaginary method. So when you read mean, you can understand what the meaning of mean. Mode, what's the meaning of mode and when it's used. What's the meaning of standard deviation, and what is the meaning of confidence interval, and what's the meaning of the p-value. So when our data is equally distributed around the point of zero, so the spread of the data is fairly similar on each side of the midpoint. What we can use in this situation, we can use the mean. And what we mean by the mean? The mean is the sum of all the value divided by the number of the value. So the mean is used only when the data is equally spread fairly around the midpoint. And this shape, we call it bell-shaped distribution of data. But what will happen if the data is not equally distributed around the zero? In this shape of distribution of data, we cannot use the mean. What we can use is the median. It's used to represent the average when the data are not symmetrical. And it is the point which have half the value above and half the value below. When we need to label the most frequent occurring events, we will use the mode. For example, if we decided in one clinic we have 100 patients, what is the body mass index, the most frequent body mass index? We distribute the patients into body mass index more than 40, 35 to 40, 30 to 35, less than 30. From this graph, you can find that the most frequent body mass index, which is accounting for 60% of the patient, is more than 40. So the mode of the body mass index in that clinic is more than 40. Incidence is the number of new events that have occurring in specific time interval divided by the population at risk at the beginning of the time interval. So the result giving the likelihood of developing an event in that time interval. For example, if we are talking about the patients who is having diabetes. So the incidence of diabetes in Kingdom Saudi Arabia, it's the new events of the patients developing diabetes in a specific period of time. Where the prevalence is talking about the number of individuals with a given disease at a given point in time, dividing by the population at risk at that point. So when we are talking about the prevalence, we are talking about how many people in Saudi Arabia they have diabetes. Whereas the incidence, we are talking about how many new patients will be diagnosed as diabetes in Saudi Arabia. The point prevalence refers to the proportion of individuals with a condition at a specific point in time. And the period prevalence refers to the proportion of individuals with a condition during a specific interval or period of time. Don't forget that the parameter is describing the population, where statistic is describing the sample, and we will explore this two statement more while we are processing this lecture. When we are talking about a clinical study, we are going to talk about one of the three entities. Remember that we will explain more and more about this clinical study and how they are conducted in another lecture. But in summary, the clinical study divided into review, observational study, and the clinical trial. In a clinical trial, there is an intervention. The clinical trial, it is a randomized controlled trial where there is an intervention occurring in the intervention group, and you have to compare it to the control group. When we are talking about the review, we will talk about it in this special lecture, but we are talking about systematic review, which is a qualitative method, and the meta-analysis, which is a quantitative method. When we are talking about the observational study, we are talking about two important entities, a qualitative and a quantitative. The qualitative is like case report and case series, and the quantitative is cohort and case control. In cohort, you have a retrospective cohort or prospective cohort, and more will be explained in separate lecture about the clinical study. When we are going to talk about standard deviation, we are going to talk about a value is spread around the average equally. So when we talk about the first standard deviation, from plus first standard deviation to minus standard deviation, 68% of our sample is located. So the majority of the sample is located between the first standard deviation plus and minus. When we are talking about the second standard deviation, we are talking about 95% of the sample is located plus and minus. So the range of one standard deviation above and below the mean, plus or minus one standard deviation, including 68% of the value. The range of two standard deviation above and below the mean, it's including 95% of the value of the sample. And if we are talking about the third standard deviation, we are talking about 99.7% of the sample. What is confidence interval? Confidence interval are typically used when we want the range that is likely to contain the true populational value rather than the mean value of the sample. Confidence interval depend on the size of the confidence interval is depending on the size of the sample. So if we used a small size sample, we will have wide range of confidence interval. Whereas if we used a large study sample, we will have a narrow confidence interval. Confidence interval will be plotted in either the forest plots or what we call the plopography. You can see it here in this picture. The p-value or the probability. What that mean? It's used when we wish to see how likely it is that the hypothesis is true. The p-value gives the probability of any observed difference have been happened by chance. What that mean? We'll talk about it now. The p-value probability of obtaining a sample more extreme than the ones observing in your data, assuming that the null hypothesis is true. The p-value is located in the extreme. When we look to this graph, we can see that the 95% of our sample is located between the two standard deviation above the mean and two standard deviation below the mean, and the p-value located in the extreme. We will look now and we will understand the meaning of the p-value. To be able to understand the p-value, we are going to give an example. Assuming we have a patient who having preterm labor, and somebody is telling us that there is a drug, we will label this drug as drug A, and this drug A is effective in stopping the preterm labor. So we are going to test the drug A to stop the preterm labor. The null hypothesis is still that this drug A is ineffective, not going to stop the preterm labor. The alternative hypothesis is saying that the drug A is going to stop the preterm labor. So actually we have two groups, the experimental group receiving drug A and the control group receiving the placebo. The result of the test came that the p-value for this experiment is the p-value is less than 0.05. That means the test is significant. A p-value is measure of the effect of the chance within the study. What that mean? Let us understand the p-value so we will not miss it anymore.
In this example, we have a company who's claiming that they have drug A, which is effective in stopping the preterm labor. Remember that the null hypothesis is telling us this drug is ineffective in stopping the preterm labor until you proving otherwise. So the alternative hypothesis is telling that this drug is effective in preterm labor. To be able to reach to the conclusion, is it effective or not effective, we will try this medication. And if we try this medication the first time for the patients, we have that, and it's a stop the preterm labor, how we are going to interpret it? We will say that, remember that we are in favor of the null hypothesis. This drug is giving the effect, which is stopping the preterm labor, by chance 50%. It is effective by 50%, giving the chance by 50%. If we repeat this drug with another patient and if it gives the same effect and it is stop the preterm labor, that means this effect to be by chance dropped from 50% to 25%. And if we repeat it for the third patient, this effect to occur by chance is dropped to the 0.12%. And if we repeat it for the fourth and it is effective, then it's by chance the effect to be by chance is dropped to 0.06. And if it's the fifth time, 0.03. If it's the sixth time, it is 0.01. But if we try this medication and one time it is effective, the other time is not effective, the third time effective, the fourth time it is not effective, the fifth time it is not effective, then we get to the conclusion if this p-value it is less than 0.05, that means that the effect of these medications to occurring by chance, it is more than 5%, which we are not going to buy or we are not going to accept. We will later on talking about the clinical significance and about the statistical significance, and in some study they are going to buy a p-value less than 0.05, especially in new medication where is no treatment for certain for specific diagnosis. But for meanwhile, we know that if the p-value less than 0.05, that means this medication is not occurring by chance. 95% this medication is due to the intervention. So if the medication successfully stops the preterm labor in all these patients, that means it is not occur by chance. So the more low the p-value, the more significant the result. Why we choose in our study 0.05? Statisticians agree that if any medication is effective 95% or the intervention is effective 95% in 95% of the tested group, that means this is significant. But of course, the more you are having the value less than 0.001 or 0.01, that means it is occurring by chance by 1%. That means it is effective 99.9%. So the lower the p-value you have, the stronger the study is.
Rule number 1, revising the p-value. The p-value stands for the probability value at its indicated how likely it's the result occurred by chance alone. Remember that a small p-value means it's greater than the chance alone. Something happened. That means test is significant. Large p-value mean the result within the chance or normal sample. That mean nothing happened. The test is not significant. If p-value less than 0.01 or 0.05, test is significant. So rule number 1, small p-value mean that the test is significant. When we are looking in the literature, we find also the absolute risk and relative risk. We have to know which is which. We have to know which one we will depend on. Are we going to depend on absolute risk or relative risk when we are deciding if this is significant result or insignificant result? When we are looking for absolute risk, we are talking about the probability of chance of an event or a disease to occur in a group divided by number of people in that group. So the disease people divided by the number of group. When we are talking about relative risk, so from its name we call it relative. So it is the ratio of a probability of an event occurring in the exposed group versus the probability of the events occurring in the non-exposed group. So the ratio of absolute risk of intervention to the absolute risk of the control. So to understand which one we are going to rely on, the absolute risk or relative risk, we are going to take an example. In this example, a company claimed that this drug A is used for the treatment of recurrent pregnancy loss. We have a control group and we have the intervention group. 300 patients, control, all of them, they receive nothing. They receive placebo. So 90 patients developed abortion. So the absolute risk is 90 out of 300. And that's mean the absolute risk is 30%. The intervention group is 300 also. 50 patients have abortion. So the absolute risk is 50 divided by 300, which is equal to 0.18, which is the 18%. If you look for it, absolute risk reduction, it is reducing from the control, which is 30%, to the intervention, which is 18%, it is 12%. So absolute risk reduction, it's 12%. What that mean? Intervention lower the risk of abortion by 12%. Let us look to the relative risk. The relative risk, we will divide the intervention, absolute risk of the intervention, divided by the absolute risk of the control. How much risk for abortion remaining among those exposed to the intervention? So 18 divided by 30 will equal to 60%. So how much of the abortion reduced in the intervention group? It will be a relative risk reduction. It will be 100 minus 60 equal to 40. That means intervention reduced the risk of abortion by 40%. Why that is important? You have to understand now. You understand now the relative risk, and we will see the next.
So what will happen if the baseline is low or high? If the baseline is 30%, assuming that the baseline is 30%, which is the absolute risk of the control group, it's the same as the baseline, which is equal to 30%. The absolute risk reduction, it will be 30 minus 18, which will be 12%. So when we are talking about the relative risk, we are talking the absolute risk reduction divided by absolute risk in the intervention group divided by absolute risk in the control group, which is 18 divided by 30, it's equal to 0.6, which is equal to 60%. So relative risk reduction in the intervention group is 40% because we are subtracting. The risk itself is 60%. So risk reduction, it's 100 minus 60, which is equal to 40. Look to this diagram and we can see that the absolute risk for the control group is 30%. Absolute risk reduction in the intervention group is 18. The difference between the 30 and 18 is 12%. This 12% is equal to the risk reduction in the risk reduction RRI, which is relative risk reduction. The relative risk reduction here is we are reducing from 30 to 12. So relative risk reduction in this example, the 40% relative risk reduction is equal to 12%. So you are going to reduce the incidence of abortion by 12%. To be able to understand more how much it is important to know the absolute risk, look to the continuation of this example. To be able to say that this risk, significant or insignificant result, we will look to this same example. What happens if the baseline risk is low? So if the abortion by itself, the baseline risk in the control group is 10%, that means the absolute risk in the control group is the same as the baseline risk, which is 10%. So absolute risk reduction will be 10 minus 6 will be 4%. Relative risk reduction, it is the same. It will not be changed. It is 40%. But it will be 40% out of 10%, which is equal to 4. So now, without knowing the absolute risk, you wouldn't know that this 40% relative risk reduction, it's count only for 4% from the control group. So are you going to buy this medication, which is maybe very expensive, exhausting your budget, for only 4%, where in the previous example, when the relative risk, when the absolute risk is occurring in the population is 30%, so you are going to reduce the risk by 12%. When you know that the absolute risk drop, that means the relative risk reduction, you cannot interpret it alone. You have to interpret it with the absolute risk. Again, this is very important where you are planning for future in your healthcare organization. All of us having limited budget in healthcare organization. Am I going to introduce a new drug, expensive drug, to count only in the reduction, in the relative risk reduction? When they are interpreted, the company, they came to you and they tell you that this medication is used for whatsoever, and the risk of development like kidney impairment in this disease, in this medication, is dropping from the baseline by relative risk reduction is 40%. So the next question you are going to ask, what is my absolute risk? If the absolute risk of the kidney function test for the normal population or with the conventional medication is 10%, different from the conventional medication, their absolute risk, it is like 30 or 40%. So if the old medication or the non-interventional medication is going to impair the kidney function of the patients by 40 or 30%, and this medication is going to drop 40% out of this 40%, different from telling me that this medication, the conventional medication, is impairing the kidney function test by 10%. So I'm going to reduce 40 out of the 10%. Why this is important? Again, important in planning for future changing in the healthcare organization or shifting from one medication to another medication. Of course, there is a clinical significance in reducing the kidney function test in all our patients, disregarding the percentage, but as tight budget in healthcare organization, I'm not going to really changing my strategy to buy more expensive medication in a way to just only reduce 10% where I have to have where there is my budget should be spent on vital and more important thing rather than only this 4%.
Now we are going to talk about the odds ratio. Remember that odds ratio is only calculated when there is two results, either getting the intervention or not getting the intervention, like getting the education, not getting the education, getting the vaccination, not getting the vaccination, or getting the breastfeeding or not getting the breastfeeding. So how we calculate the odds ratio? We remember that data shouldn't be used for decision making because it is hypothetical situation, and the intervention, which is like education about the vaccination in this example which we are going to mention. For example, there is two group. There is an intervention group, there is control group. We are giving education about the vaccination and pregnancy for the group, and the other group we didn't give any intervention. And we will see how many patients getting the flu shots, which is in the intervention 80%, in the control group 55%. The patient who didn't getting the flu shot despite interventions, they are 20%, and in the control group they are 45%. So the odds is 80 divided by 20, and in the control 55 divided by 45. So the odds ratio we will use the events occurring in the number getting the intervention divided by the events occurring in the number who didn't get the intervention. So the odds ratio will be 4 divided by 1.22, which is 3.3. Again, odds ratio calculation shouldn't change our decision because it's hypothetical situation. So how we are going to interpret the odds ratio? We know that odds ratio is events occurring in the number getting intervention divided by the number who didn't get intervention. So if the number getting intervention divided by the number who didn't get intervention equal to 1, that means it's insignificant. No difference. If the number of getting intervention divided by the one didn't get intervention more than 1, that means positive result. What about if it's less than 1? It means negative result. Remember that odds ratio of 3.3 mean group have get intervention vaccinated more. But for this example per se, it is positive. But odds ratio not always positive. Sometimes more than 1 mean positive or can be meaning negative, and we will have more example to elaborate on this. And the odds ratio less than 1 can be positive or can be negative. So case control study cannot calculate the risk but can calculate the odds. In the case control study, start with the outcome and search for the exposure comparing to the control who do not have the disease and check for the exposure. Our example is down, look for 10 patients who have BET, patients who do not have BET, assuming that we are looking for the exposure for anything, A things. So how many of those patients who have been having PET have been exposed to the A subject? How many of them have not been exposed to the A subject? And how many of the exposed have been developing the BET? How many of them not developing the BET? So then you calculate the odds ratio. You can calculate the odds ratio, but you cannot calculate the relative risk and relative risk reduction. So before you interpret the odds ratio, look to the confidence interval. Before interpreting the odds ratio, look to the confidence interval. For the example, if the odds ratio is 5, and if you look to the confidence interval, and you find this confidence interval crossing the line of no difference, that means even if this value, the odds ratio, is significant, if the confidence interval across the line of no difference, this odds ratio will be statistically insignificant. We will explain it more in the next slides.
In control trial, we have an intervention group where we are trying trying a new medication or a new method of the diagnosis. In this control trial, how we could determine whether an association exists and how strong this is association. This can be done by statistics. Statistical significance like p-value or confidence interval and relative risk. Comparing the probability of an event occurring to all possible events considered in a study. Remember that relative risk is calculated for cohorts and randomized control study, whereas relative risk cannot be calculated for the case control study, but we can calculate the odds ratio. Why? Because in the case control study, you cannot look for the intervention. So there is no intervention in the case control study, so you cannot decide the relative risk. So remember that cohort randomized control study can have relative risk, can have odds ratio, can have p-value, confidence interval. Whereas in a case control study, you cannot have relative risk, but you have odds ratio. And when we are talking about the cohort study, whether this study is retrospective or prospective, or we are talking about the randomized control study, we are talking about two groups, the intervention group and the non-intervention group, or the exposed group and the non-exposed group. So the intervention group, some of them they will develop the disease, some of them they will not develop the disease. And the unexposed group or a non-interventional group, some will develop the disease, some will not develop the disease. So what we are calculating, the disease risk incidence in exposed group, and this is what we call the absolute risk for the exposed group. It's A divided by A plus B, which is the population of the exposed group. And when we are talking about the disease risk incidence in unexposed group, we are talking about the absolute risk in unexposed group, which is C divided by C plus D. The relative risk is equal to the absolute risk in the exposed group divided by the absolute risk in the unexposed group. The result will come out. So if the result is equal to 1, that means البسط equal للمقام، يعني عدد الناس اللي develop the events in the exposed group بيساوي عدد الناس اللي develop the incidents in the non-exposed group. معناها they are equal. معناها الانترفنشن اللي احنا سويناه كان insignificant. So if the relative risk is equal to 1, that means this intervention is insignificant. If the relative risk is more than 1, it can be either positive or negative. And if the relative risk is less than 1, it can be negative or positive. And we will explain more in the two examples which you will see, where the relative risk positive, it means negative, more than 1 is positive, and the relative risk is more than 1, it can be negative. You cannot comment on the relative risk without commenting in the p-value and the confidence interval, and we will have example for it too. Let us take the first example where we are studying the BET and the exposure to smoking. We want to know if there is any relationship between exposure to smoking and the development of BET. We have two groups. One is unexposed group, which is the control group, and they are 100 patients or 100 persons. And the unexposed and the exposed to the smoking, where they are 100. And we are going to calculate how many of these is exposed to smoking will develop the disease, which is the BET. Assume in this study that the exposed to the smoking, 30 out of 100, they develop the disease. That means the absolute risk for the BET, development of BET in smoking group is equal to 30 divided by 30 plus 70, which is 100. And it will be equal to 0.3. In unexposed group, you can see that the people who developed the preeclampsia, they are people developing preeclampsia, they are 10. So 10 absolute risk, 10 divided by 10 plus 90, which is the 100, then this will give us 0.1. When we want to calculate the relative risk, we will divide the absolute risk of the intervention divided by the absolute risk of the non-intervention or unexposed group, and it will be 3. 3, it is more than 1, it is have positive effect. What that mean? That mean that that smoking have positive effect in increasing the risk of BET. And this is positive risk. If it's more than 1, it is positive in this meaning. We will take another example, is exposure to aspirin. So we have a control group who they are not exposed to aspirin, and we have the intervention group where we give them an aspirin. And we will study the relative risk. So relative risk, as we explained, it's the absolute risk in the exposed or in the intervention group divided by the relative risk of unexposed or unintervention group. In this example, we found that the 10 patients developed a BET in exposed group, which is 10%. And we have 30% developed BET in the non-exposed group, which is 30%. By dividing 0.3 over 0.1 equal to 0.33. What that means? Relative risk is less than 1. Relative risk is less than 1 mean that we have a positive effect. Because by explaining that, we are relative risk less than 1 not always is negative. Relative risk less than 1, sometimes it is negative and sometimes is positive. In this example, the risk of development of BET in exposed group is less than the risk of development of BET in the non-exposed group. And the relative risk of less than 1, in this example, it's giving us a positive result. We'll continue with the same example, where we have the exposed group to the aspirin, they develop 30% BET, whereas the non-exposed group for aspirin, they develop 10% the BET. That means the relative risk, it is the risk of the people developing BET in exposed group 0.3 divided by the incidence of unexposed group, which is 0.1, which is equal to 3. What that means? That means relative risk is more than 1. Relative risk is more than 1. In this example, it's a negative effect. That means aspirin increasing the risk of development of BET. So when we are interpreting the relative risk, we have to know what is the question of our research or our study. Assuming with the same example, 10% of the patients developed BET in the interventional group, 10% developed BET in the non-interventional group, that means relative risk equal 10 divided by 10, which is equal to 1, which is equivocal. That means it doesn't matter whether we giving the patient aspirin or we didn't give the patient aspirin, the result will be equivocal. So the result of this study, relative risk, is telling us equal to 1, that there is no benefit from the intervention. When we are going to interpret the relative risk, we said we have to look to the confidence interval. At the same time, we have to look to the p-value. So if the p-value is not less than 0.05 or the confidence interval, including the crossing the line of no difference, which is 1 in relative risk, so this study is not significant no matter how large or small this study is. But if the p-value is less than 0.05 and the confidence interval crossing the line of no difference, which is 1, that's also still this study, it will be considered as insignificant. So the relative risk, it doesn't matter if it is more than 1 or less than 1. To be able to interpret it, you have to look to the confidence interval, and the confidence interval, it shouldn't cross the line of no difference, and the p-value, it should be 0.05. So as we can see that the confidence interval play a very major important role in interpretation of the study result. even if it is statistically significant, less than 0.05, even if it is the relative risk is more than, with a positive relative risk is having positive value, more than 1, or positive value with less than 1 according to the question of your study. If the relative risk is crossing the line of no difference, this study will be considered invalid. Let us take a fifth example where we are having intervention, and we are going to test a new drug. So remember, the null hypothesis is telling you this drug ineffective till you proving otherwise. And what we are going to do, we are going to test this new drug in a sample size of 100 patients for the intervention group and 100 patients for the, or 100 patients for the non-exposed group or the control. We start to collect the value of reading the blood pressure in the patient's BET and the patients whose diastolical blood pressure more than 110. In this example, we are going to test a new drug, and this drug, it's telling us that this drug is as effective as hydralazine or superior to hydralazine in the controlling the blood pressure. We start to collect the value of reducing the blood pressure in the BET patients whose diastolic blood pressure more than 110, and we use the 95% confidence interval. That means we did the calculation 95 patients, and we found that the minimum blood reduction was 95, and the maximum blood reduction was 85, and the confidence interval between 95 and 85. The mean arterial blood pressure in group A is 95. We calculate the mean arterial blood pressure reductions of a group B is 85. So the reference range of us, it is between 95 and 85, which is minus 10. The next step, we are calculating the p-value, and we find that the p-value is less than 0.05, which is equal to 10. So we interpret the result to be statistically significant. So the drug A is effective in reducing the blood pressure by minus 10 millimeter mercury, comparing to the drug B. To calculate that, we have to calculate first, to interpret this value, as we said carefully, we have to calculate the confidence interval. And when this study repeated 95 times, we found that the least reduction of the mean arterial blood pressure was minus 1, and the maximum reduction of the mean arterial blood pressure is minus 15. If you look to the confidence interval between minus 1 and minus 15, we find that the drug A is reducing the mean arterial blood pressure by minus 1, which is clinically, despite that it's falling down, all of it's below the value of 0. Because we are talking about reduction, the value of 0 of the line of no difference, it is minus 1, and the limit is minus 15, which is clinically significant. But am I going to change my practice on minus 1? This is our patients, our study, it's fall down at minus 10. So confidence interval give you information about the precision than the p-value. So this is then we will go and we will interpret it. This minus 1 in a patient who is BET. Are you going to start a new medication which is only clinical significance on this patients, clinically reducing the blood pressure by minus 1, where you aim to reduce the blood pressure at least by minus 10? So from here, despite that the p-value telling you that this is significant, from the confidence interval, you can say that this is clinically insignificant. So I'm not going to shift my practice for a drug which can put my patient in hazard. As we said before, point of no difference, if we are dealing with a subtraction, a reduction, it like a reduction, the point of no difference, it will be 0. But if we are dealing with ratio and odd ratio, the line of no difference will be 1. The smaller the confidence interval is, the better the study. So to reduce the confidence interval, you have to increase the sample size. Let us talk about another example where we are going to test the risk of the development of iron deficiency anemia in antenatal care. The intervention which we are going to introduce here is educational material for a primary healthcare center and in the first trimester, and we are going to test the hemoglobin in the second trimester, and we will see that the risk of the development of anemia of the second trimester, how much it is. There is two groups, there is study group and there is control group, and if the study group found to be that the relative risk of the development iron deficiency anemia is 0.6, that means 40% reduction in the development of the iron deficiency anemia. So we think that it is statistically significant. We look to the p-value. The p-value is less than 0.05. And then we will look for the confidence interval. In this study, we find that the confidence interval doesn't cross the line of no difference. That means the educational material was sufficient enough to reducing the iron deficiency anemia in all our populations if it is repeated 95 times. With a relative risk of 0.6. The confidence interval risk, it is between 0.3 and 0.9. And when we are talking about the relative risk, we are talking about ratio. So when we are talking about the ratio, the line of no difference is 1. In this study, the value, it is statistically significant by the p-value, and by the confidence interval, it doesn't cross the line of no difference. That means that our intervention, which is the educational material, was enough this study to be statistically significant. But if we took the same example, and we found that the relative risk is 0.6%, with the p-value less than 0.05, but when we look to the confidence interval, we found that the confidence interval crossing the line of no difference, where some of the patients they have developed more iron deficiency anemia, and whereas the range, the sum of our patients, you can see here, some of them crossing the line of no difference and they're developing the iron deficiency anemia, and the majority of them, they are not developing the iron deficiency anemia. What that mean? That means this study statistically insignificant and the intervention is ineffective. We have to analyze more, look more to our research or to our intervention, to the material of education, and you cannot generalize this educational material for all the population because it's give a negative effect in and it crosses the line of no difference. So now we agree that the confidence interval, the study which is having confidence interval, will be considered more complete and more informative. The more confident you want to be, the higher you will go. So when we are talking about confidence interval of 90%, that means we repeat this study 90 times. But if I want to be more confident, I will have a confidence interval of 95%. There is some of the study, they will write confidence interval of 99%. And this study, which is including major changes on the patient's treatment, and we want to be sure that this study is not crossing the line of no difference by any means. So the point of no difference can be 0 or 1 again, repeated again and again. It will be in reduction, it will be 0, and in ratio, it will be 1. So if the result shows statistically significant but confident interval across the point of no difference, this result will be considered to be clinically insignificant, even if it is statistically significant by the p-value less than 0.05. What is odds ratio? What is the difference between odds ratio and relative risk? Odds ratio, it is probability divided by 1 minus the probability. What that means, when we are calculating odds ratio, we are divided ratio by ratio. What is the difference between relative risk and odds ratio? Odds of the cases was exposed. That means the patients who developed the disease and exposed to the intervention divided, or the ratio divided by the unexposed, the patients who developed the disease and unexposed. So we have the ratio between the patients who is developing the disease exposed to the ratio for the people who is developing the disease unexposed. And we divide it by the odds of the unexposed. That means the patients who is not developing the disease and they are exposed divided by the patients who is not developing the disease and unexposed. So the odds ratio it's ratio divided by ratio. in the في البسط في عنا A divided by C which is exposed by the non-exposed, but في البسط في عنا كلياته عبارة عن disease. في المقام we are divided B divided by D which is exposed to non-exposed, the patients who didn't get the disease. Interpretations of odd ratio, it is if it is 1 that mean no difference مثل ما قلنا بسط على مقام. إذا كان الجواب 1 فحيكون no difference. Whereas the odd ratio more than 1 that mean there is a positive effect, and less than 1 it is negative effect. Remember that odd ratio can be calculated for both cohort and case control design, where relative risk cannot be calculated for the case control design. The term used to describe the quality of measurements, reliability, validity. What is the difference between reliability and validity? Reliability is referred to the extent to which repeated measures of relatively stable phenomena fall closely to each other. That means if I take this test and do it here, or do it in USA, or do it in UK, the result should be the same. It doesn't matter if you did this test in the Eastern Province, in the West, in the South, in the North, the result will be the same. So this test is more as a reliable test. So reliability of the test is telling you no matter how much you repeat this test with different people, it will fall down with a narrow range of difference. The kappa statistics are often interpreted as excellent with 0.8 to 1, good 0.6 to 0.8, moderate 0.4 to 0.6, fair 0.2 to 0.3, and poor less than 0.2. Where when we are talking about the validity, we are talking about the extent to which an observational reflecting the truth of the phenomena being measured. So this is the valid test. It's telling us that this test is reflecting the truth of the results. There is several types can be measured: content validity, construct validity, and the criterion validity. In content validity, the extent to which the measure reflecting the dimensions of particular problem, and construct validity, extent to which the measure is affirmed by the external established indicators, and criterion validity is the extent to which the measure can be predicted and observational phenomena. When we are talking about validity and reliability, most probably we are talking about a test. This test is valid and reliable. High validity, high reliability, let's give the test is a good outcome. Again, as we are talking about the test, we are going to talk about the predictive value of the test. There is a positive predictive value and there is a negative predictive value. When we are talking about positive predictive value of the test, we are talking about representing the likelihood that the patient with positive test have the disease. What that means? That when we are talking positive predictive value, that this patient who is having the disease will be tested positive. The negative predictive value represented the likelihood that the patients who have negative test is free of the disease. So you cannot get a test. We said we will do the test A, and we are going to test for the syphilis. And this test turned to be negative, and we tell the patient that she is not syphilis, then she turned to be syphilis. So negative predictive value is telling you that a negative patient is negative. Whereas positive predictive value is telling you that a positive test means that you are having the disease. For example, VDRL test. The VDRL test, all the positive patients of the VDRL will be tested more. So positive predictive value used is very high for VDRL to detect the patients who is most likely to be a syphilis. But this test, if it is negative, unlikely that this patient is not is having syphilis. So negative VDRL is telling you that this patient is unlikely to be syphilis. Whereas a positive predictive value is telling you that this patient is likely to have, if it's positive, to have a syphilis. And here when we are talking about positive and negative predictive value, we have to talk about specific sensitivity and specificity. So VDRL test, it is very sensitive test. What means very sensitive test? It means that it tests positive in disease patients is high comparing to the people who is tested, whether they are positive or negative. So in a group of population, we have the sensitivity, it's A divided by A plus C. So all the patients who having the disease, like syphilis, how much of them test positive? So those patients, if it is 99, that means the sensitivity of this test is 99%. And that means I'm going to detect 99% of patients who having syphilis, where I'm missing one patient who have syphilis, and the test is negative. And that's telling me that, look here, so the test positive, A divided by A plus C. This is a sensitivity. So how much this test is sensitive to detect the disease. The more sensitive that the test is sensitive for detecting the disease, the more it is having high sensitivity. Like we said, VDRL, it detected most of the patients, like 99% of the patients who is having syphilis, they will test it positive for VDRL. Is it specific? No, it's not specific. So to be able, because some of these patients, they are positive, but they are not syphilis. So how I can differentiate between specificity and sensitivity? A specificity, it is the specific test for a specific disease. That means the D, which is the test negative and the disease absent, divided by B plus D. So how many of the patients tested negative upon the negative patients? So I'm not going to test, the test will not give me a negative result, and at the same time, the patient is positive. So again, a specific test, like if you do use sensitive test for the screening, you can use sensitive for the screening, but a specific test is for the diagnosis. So a test who is having high sensitivity and high specificity, it will be considered good test, because it will be, you can be used as screening and can be used as diagnosis. Positive predictive value, it is A divided by A plus B, and negative predictive value, it is D divided by C plus D. So here is negative, and here is positive. Positive disease, positive test. Here is negative disease and negative test. I hope in our first lecture we could clarify some of the statistical important point when you are interpreting any value, the p-value, confidence interval, relative risk, absolute risk, and so on. I hope that we could clear it. This is very important. You have to understand it. You could attend this lecture as long as you can, till you feel that you are satisfied with all the understanding of all the statistical things. If you don't understand anything, you could contact me in the WhatsApp of this number, and I would clarify the point which you are not feeling happy or feeling not satisfied about it. Our next lecture, we are going to talk about, this is the next lecture in the evidence-based course. We are going to talk about the type of the review, the meta-analysis, how to interpret them. Then we are going to talk about how to critique critical appraisal of the article step by step.